Hi everyone, I'm Candice Groenewald and welcome to another session of the HSRC Connect. Now today we have a very interesting panel that's going to talk to us about the longest standing survey in the HSRC, right? I've got that right. And that is our SABSSM survey. So now if you are anything like me, you use the acronym SABSSM, but you don't really know what it stands for. And I'm going to read it out to you. So it stands for the South African HIV Behavioral Serostatus and Media Impact Survey. So I think SABSSM is a little bit better for the tongue. So we have an interesting panel with us today that's going to talk about the history of SABSSM, how it came about, but also the important resource that the information provides for us as researchers, but also for people in our communities and our families to understand the public health of the South African citizen. So without further ado, I'm going to ask our panelists to introduce themselves, and then we're going to get into our discussion. So we'll start with you.
Thank you very much. I'm Professor Kangelani Zuma, Divisional Executive at Human Sciences Research Council and the overall principal investigator in SABSSM.
Yes, and one of the people that has got the longest standing servings on SABSSM right now, right? Welcome.
Thanks.
Thank you. I am Dr. Pelagia Mranganti. I'm from CDC Epidemiology and Strategic Information Branch, and I am a public health specialist there.
Great. Thank you.
Thank you. My name is Patrick Mdleje. I'm the Deputy Chairperson of Civil Society in KwaZulu-Natal, but I'm also working with CAPRISA.
Okay, so we like I'm this person, but I'm also working with CAPRISA. Now, you are very welcome, all of you. It's such an achievement for us in the HSRC to be able to say that we've got a survey that's 20 years standing and going, right?
And still going.
And still going. So we want to just briefly speak about how did the survey come about? Where did it start? How did you become involved in the survey? So if you, Kangelani, could maybe give us a little bit of a background on the survey and how that started.
Sure, thank you very much. The first study was actually pioneered by our former president, Dr. Mandela. This came about, after the president was very concerned that actually almost every weekend, I'm told, when he wanted to see and visit family members and all that, one of the engagement that used to happen every weekend that his close relatives would find themselves engaging in were funerals. So almost every weekend, one way or another, there was a funeral somewhere of a close relative. And at that time, HIV epidemic was really ravaging the country. And they said, you know what, we need to get to the bottom of understanding where we are, what is this epidemic, how many people are living with HIV. And therefore, people were approached at Human Sciences Research Council. Our former principal investigator, who was the executive director at the time, Professor Olive Shisane, was the first principal investigator in this study. So that's where she put together a team, and funding was received from the Nelson Mandela Foundation. And that's where the study started. And later on in the second wave of the survey, CDC joined in 2005. And CDC has been there with us from 2005 up until today, and hoping that CDC will continue being with us until we're completely HIV and AIDS free.
Yes, and hopefully that will be very soon.
I hope so.
No, that's great. And I think, and how did you start getting involved in SABSSM and just your role?
I came, I think, at the time when the SABSSM team was doing the analysis, about 2002, 2003. Then I joined the team as a statistician, maintaining statistics. I just completed my PhD, so I came in at the time when data was being analyzed and publications were conducted. And in fact, today, most of us who are part of this project were actually junior researchers. Some of our colleagues were research trainees at the time, and they are now doctors and have done their PhDs through the study, and they're now leading the study. Actually, the whole team leading the study was the team of junior researchers at the time when it started.
I think that is so profound because we often think of surveys as related to the findings and the outcomes, but it's also spaces for people to grow,
to develop.
and also establish themselves. And I think, as you start, especially when you're starting out, you have a certain way of thinking and experiencing the world, and then you start engaging and you grow, as you said, and now you've got people that are seniors on the team that are engaging, so that's really great. So I want to now talk about the outcomes of SABSSM. And for those who don't know, there is so much information collected in SABSSM. So it collects information around, and I'm going to try not butcher this, the biomarker-derived indicators that it collects. So indicators such as HIV prevalence, HIV incidence, ART use, and a long list of other things that's included, but also behavioral indicators. So HIV testing history, self-reported adherence to ART, condom use, sexual debuts, and so forth. So the information is really rich that you get. And I think what's also great about it is that it covers various provinces. It's not just in one space. So could you, Kangarani, maybe speak about how valuable is this information? How much of a resource is it for us in our country?
Thank you, Candice. If you remember, you look back, the only information we used to collect at the beginning was to test whether a person is living with HIV or not, so we could know the prevalence, and that was it. So we know that there is a problem. It's like we had no way to deal with it other than educating people about the problem, but we really didn't have a way of directly intervening. But now, because of the different biomarkers that we test for now, a person that tests HIV positive, we can actually talk about a person being tested whether he's on ARVs or not, because of what has been done to date that people now have access to ARVs. We can actually test if a person was recently infected, so that we can estimate the rate of new infections due to the test. We can test, for example, the viral load level. And the other aspect that we have not spoken about, the drug resistance.
Right.
We do a test where we can test whether a person on ARVs or not on ARVs is actually having any resistance to a particular drug.
Wow.
Because one of the problems that happens is that data is being analyzed. But one of the challenges that happened in HIV epidemic, when people are living with HIV, they are on ARVs and they continue engaging in unprotected sexual intercourse, not being virally suppressed. They're likely to transmit the virus, and also we find that some people actually they develop resistance to a virus, to a drug, even before they are on treatment. That's what we saw in the previous surveys. So these are all biomarkers that are collected so that we can understand all the dynamics of HIV epidemic. We can know where the problem is, who is at high risk of HIV infection, and also have an idea of what interventions are actually having an impact.
Right.
So those are things that we're able to extract.
And I think what's also great about the survey is that it's not just the biomarkers, right? It's also these behavioral indicators that tells us about those outcomes, and also guides us then around how do we address this. It becomes such an important resource in that way. So great, thank you. Pelagio, for you, why is this program so important to the CDC?
Okay, so like Prof said, SABSSM provides essential data on the HIV epidemic in South Africa. And this data has been used to monitor and to guide HIV programming in South Africa, including HIV prevention programs like the voluntary medical male circumcision program, like the pre-exposure prophylaxis program, like the DREAMS programs for adolescent girls and young women. And in addition, this data is used to calibrate HIV estimates, models like the Tembisa model, the Naomi model, which is used in the data-driven HIV program planning in the country. So it's a very important resource in that regard.
Yeah, no, that's great. And what for you has been standing out around just the learnings that you've encountered with? I know there's a lot,
Yeah.
and I know that you are busy engaging on all these learnings in different spaces and places, and I'm sure that this must look differently in different spaces. But for you, just what stands out for you?
I think what stands out with the SABSSM is that it's a national survey that is led by South Africans
Yeah.
to improve the lives of South Africans.
Right.
And as said before, it's a platform that continuously trains and develop new researchers, a next generation of researchers.
Yeah.
So there's no short of talent
Yes.
with SABSSM.
Yes.
There's always people who have got the history, who know where it came from,
Yeah.
where it's going. They understand. They can tell you what happened in
Yes.
2002, for example. There are not many organizations that we have that institutional memory that is within the organization and that can be used to keep the work going forward.
Yes,
And
yes.
we know that they are capable to do that.
Yes, and I think what's for me standing out is, and I guess my question to both of you as key workers within this survey is, how did you make it last for 20 years? I mean, it's a long time, and it's we know that from a research perspective, it's so difficult to keep surveys going. But we also know the resource that it is. So how did you keep it going for 20 years?
Well, I think it's because of the impact that HIV epidemic has in the country. I mean, we as South Africa, we hold an unfortunate record of being a country that has the largest number of people living with HIV. So it's a serious challenge. If you look, for example, in KwaZulu-Natal, almost 2 million people are living with HIV.
Wow.
The 2 million people, like the 1.9 to be close, is higher than the 1.3 million people of Swaziland. The population of people in Swaziland
Wow.
is 1.3.
That really puts it into
The
perspective.
population of Lesotho is 2.3 million. So actually, the numbers of people living with HIV in KwaZulu-Natal is actually closer to the population of the entire people of Lesotho. So it just shows the magnitude of the situation as far as HIV epidemic is concerned. So that is one part. But the other aspect is, obviously, we as researchers, we could dream about doing this work, we could see the need of doing this work, but if we do not have partners that are willing to put funds for us as a country to deal with this epidemic, we could only dream and wish to do the study. So if the question that says, what is it that has been able to keep the study this far, is both the challenges, the real challenges of HIV epidemic in the country, but also the support from the goodwill of the American people for us to be able to deal with the HIV problem in the country. So those are the two aspects that have brought us to where we are.
No, great. Thanks for that. I think this 20 years is just so impactful for me. Patrick, for you, I want to ask you to maybe reflect on what's the value of this work at the level of the family and communities. So as researchers, we always say, as researchers, we speak the same language. We can engage on these things and we engage here. But when we take this home, or we take this in our communities and to the families and so forth, sometimes we can it could be a hit and miss it sometimes in the way we provide the information and engage with that. So how important do you think this kind of survey that really tracks things over time for us is for the community and for families?
Maybe just to go back a bit.
Yeah.
For me, this survey, on my early days in TAC, now I'm a Deputy General Secretary of TEC.
Yes.
We've always been following it up, trying to make sense of it.
Right.
We've used it as a tool of advocacy.
Nice.
One, to try to advocate for what is actually missing and also to create a conversation between civil society and the government. and also it always empower us to speak in a position of power and facts, because we are not just drawing this from the air. We then say, go and check pay so and so. That's how
Right.
it meant for us. And also then to say, what does it actually mean then for epidemic from now moving forward? But bring it closer to home. This survey is one of the very, very important. The fact that it is done in South Africa, but also it gives you a very clear picture then to say, where are we actually going? Are we going to end this epidemic as we all want to? Or is it we are creating a complacency environment?
Right.
Then those are the two things. One part of it, you find that also when we say like today results shows that there's a decline. From time to time, we normally say this on my part to say it created complacency somehow. People thinking that we are winning.
Yeah.
It is for that reason. Then, if you were looking at the condom distribution and the condom usage in KZN, 2017 actually we were doing very better, 44% point something. Then now we declined. One part of it, probably people think that we're doing well, and then after that, then we actually relax. But for us, really at home, it tells us exactly then to say what is the task at hand and what is next that need to be done. Clearly, all the pointers for me, part of it, they were pointing to say we need to invest on behavioral change. Yes, education in South Africa, we are doing our part. Government have invested, our donors have invested significant resources. And then also civil society been doing a lot of work in that regard. But we are not investing sufficiently in terms of the actual behavioral change now. Then to say, how can we change men? Because my community in KZN, we are people who believe on talking about things, meaning community dialogues always remain as key if you want to change people's mind. I think there are some real tangible evidence that we're going to use in crafting and shaping our dialogues, and also to say who to target, and also to challenge some of the stereotypes, because we cannot run away from the fact that KZN is a very patriarchal society, and but now we are also transforming. We're in between patriarchal and anti. So we are in that transition
phase.
So which then also employ then to say we need a multi-pronged kind of strategies then to respond when you're looking at the rate on which young people are getting infected. Then it makes them to say we cannot just concentrate on Mkhosi Mhlanga, which is it's where they are we teaching young women then to take care of themselves, yet later get married to a man that have never been taught of anything. So we need to invest. For me, I'm clear in my head, we need to invest on men in terms of dialogue with men, but in terms of behavior, we need, if men can change behavior. Because I was shocked today to see so many men with multiple partners, then that speaks in volume for me.
Yeah, I think that's also the value of doing this kind of work. It creates another way of thinking. It stimulates it. It's like you said, the facts sometimes can be very cold, but when we apply our mind and we go, what does this really mean in our context, in our country? We live in a country that is so diverse, but also united in many ways. But it's also recognizing that diversity. Like, what does this mean for KZN? You know, how do we make this real here, and what do we do with that? And I wonder, just you said earlier that dialogue is so important, and I completely agree with you in that. What is your experience of how people actually engage with this kind of information? Are people shocked when they hear the statistics if you present it to them? Because I think, you know, in research, we often we engage in our cliques. You know, like we've got HIV researchers and we engage with HIV researchers, and then we've got behavioral research and like that. But then when we take the data to the communities, sometimes people are quite shocked. I'm shocked with what you just said about 2 million in Lesotho and so forth. So how do people respond in your experience?
scientists and researchers, they've done a very good job. They
Yeah.
are doing their job to translate these numbers. But
Yeah.
it is for us as advocates then to start to speak sense into these numbers.
Yes.
In real life, what does it actually mean for the community? Meaning community engagements in different platforms at the community meetings. Surely people will be bit mixed motions as I am right now as well.
Yeah.
I'm happy on other part, I'm disappointed on other things.
Right.
But then the question is, what need to be done thereafter?
Right.
What actually does this mean then for our greater population? I'm glad the government, from Department of Health, Social Development, and many others, education, they were all here. Then how can we then convert what are we actually learning from this particular study,
Yeah.
and how can we convert that in then to programs, because that's where the bulk of the matter is.
Right.
However, I must also indicate that I'm also equally worried looking at if I just go back into 2016 up until date, we've seen a serious shrinking of funding at the community level. A lot of
Right.
organizations at the community level that were doing a lot of work are closing down. Meaning government can only do that much in terms of making sure that there's enough condoms, making sure that there's enough treatment in terms of PrEP. But people who are taking the word to the community, civil society organizations,
Yeah.
yet if then that is shrinking, and also it will be weak of us to think that government can do an excellent job in terms of communication. Yes, they'll do their part, making sure
Yeah.
that their pamphlet, their statement, but the footwork, yes, government, particularly in KZN, through Operation Sukumasaka and other various means, they are trying their best. But we know that civil society is playing a huge role
Yes.
to close that particular gap. So I think there will be mixed motions, but at the very same time, there will be some excitement.
Yes.
Yeah.
Yeah. No, that's great. I mean, what I asked you earlier about what stands out for you. For you, what has been some of those things that has created this mixed emotions? What has been, if you think over the last 20 years, if you can, and you just reflect on, even if it's just the last 2 years or 3 years, or the last 3 or 4 iterations of the survey, and you've seen some of those shifts and changes as statistics normally go, right, up and down.
Yes.
What has stood out for you? Is there anything that has shocked you or that has encouraged you or just stood out?
The decline of new infections, for me, it's a big thing. Understanding that the epidemic, without having a clear or steadily declining of new infection, then that epidemic is not in control. So we are not yet there, but judging from 2004 up until today, and then you see that there's a significant stride that are made. So the new infection, reduction of new infection, yes, it's not a lot. 10,000 in how many years? 2017, 2022 is not a lot, but it's huge
Yeah.
on my part. What I'm disappointed on men, for me, that's a huge disappointment. But I also understand that is why I was saying we need to invest more on community dialogues. We need to invest more on social behavioral change programs, because there's something wrong with the way how we actually think as men. This also, in a way, influence young women, because the current unemployment have a lot to do with what we actually see. The new infection among young women, we know that unemployment undermines women independence. It also creates women to be more vulnerable. But for men, in a way, it drives a crime. As right now in our cities, if you look at Pietermaritzburg, where there's a lot of sex, Pietermaritzburg and eThekwini, look at that together with crime in these very two districts. The society demands so much out of men, then men end up doing wrong things. But in that process as well, when we're not doing anything, too much time on our hands, then sex also fits in. It's just a string of things. But I'm glad that also there were some clear pointers then to say, if then we want to achieve 1990 strategy, what then need to be done. Yes, we're doing well in terms of the test and treat, the first 90, the second 90, retention and care. Yes, we are not doing well in that. There are a lot of reasons on when we converse with the community. One part of that, people they still experience high stigma, but necessarily not the outside stigma, the external stigma. It's the internal stigma that is a problem in South Africa right now. I remember once we said the external stigma was sitting at somewhere 23 point something, meaning internal stigma, which that is too much. And then external stigma is sitting at 16 point something, which tells you that you are most likely to think that you'll be discriminated than being
actually being discriminated against.
Yes.
Wow.
And that is more dangerous than the actual stigma, the external stigma. So internal stigma is what's going to kill us. We know that most people, particularly I've seen this in Pietermaritzburg, you find Lapana Dambuza, people are not taking treatment in their local clinic. They take a taxi to another community.
Yes.
Then it tells you we really have a deep-seated kind of stigma, internal stigma. Then that brings me then to my next point then to say, Prof, I'm advocating for another cadre in South Africa, which we need to be introducing in, because the issues of psychosocial support are real. You spoke about the issues of people defaulting on treatment, which also in a later stage will develop for people to have a total treatment failure, which will cause a new treatment regimens and change. It's because there is enough in terms of poor psychosocial support aspect of things in our HIV epidemic. That aspect is not taken care of to a level that I don't even know whether we even understand to say what is the extent of danger. In my life, particularly my comrades, Comrade Prudence, Mabele, Andrew Musane, there are a lot of comrades that I know, people that were well prominent and outspoken like me. Then next thing you hear the person just got sick, shot sick like 2 months, 1 month, person died. You find that when you listen carefully and closer to family, then the person just died because he had a depression, stopped taking treatment 2 years ago, and then we are all shocked. But then psychosocial support is not there. Then also for those individuals who were newly diagnosed, sometimes what is happening because of the internal stigma, when a person is newly diagnosed and then people tend to discriminate themselves and then they don't seek help. Only go to help to clinics or hospital very, very late. So there is no bridge, or either there's no bridge between the time you find that you are HIV positive and to a time when you say you're ready to take treatment. Yes, test and treat was a way of normalizing HIV in South Africa, but we need to ensure that we strengthen these 2 points. Finding to make sure that you take treatment and you know why you're taking treatment. At the moment, most people are taking treatment because the nurse or the doctor said so. So it's more than that. Adherence, it's something that it's a personal decision. It's something that you own as an individual. It's not what your doctor said. So we are not there yet.
And I think you raise a very important point that is, I think outside even of this conversation, is that the limited respect, I want to say, we actually have for psychosocial support in our country in general, right? So having access to that kind of services, that kind of support, respecting it as something that is of value. In the same way, if you're ill, you go to a doctor. You know, if you have any kind form of situation that you need that psychosocial support, that respect is not something that we actually at various different levels have. And so that's such an important point, which comes back to your point around also just men and the stigma around even seeking psychosocial support for men, right? So it's a very complicated situation, and I thank you for raising that. I'm hoping that the researchers who are watching will be encouraged by that, because I think it's such a gap from a research perspective, a practice perspective, a policy perspective, really, to think about what would adequate, accessible psychosocial support look like. right? It's such an important component. And for you, around the 20 years, what has been something that stood out for you, or any responses that you raised?
Maybe just to add on an important point that Babu Mdletshe has raised of stigma and psychosocial support and community interventions. We see it, especially with adherence to treatment. If you look at the results, you see that young kids, 15 to 24-year-olds, living with HIV are less likely to be on ARVs.
Okay.
Even more worrying is that those that are on ARVs, some of them actually don't know that they're on ARVs. And you showed how does that happen.
Yes.
Some of them were born HIV positive. They are on treatment. Parents have never disclosed to them that actually the medication they're taking, these are ARVs, this is
Right.
how it should work, ARVs and HIV, how does it come about, all those issues. Because even parents themselves are not empowered to
Right.
be able to deal with the challenge. So
Right.
you've got children taking medication, they don't know what this medication is for. And obviously they are not owning
Yes.
this medication. And also, again, then what will happen if parents are not empowered? What do you think will happen to a parent, for example, that who has to find out now that the child is living with HIV, or, for example, that now she has to deal, a parent, a father, a mother has to deal now with a child that is living with HIV. How will the young one be able to approach the parents so that they can get the support? So those are all the challenges that we need to deal with, and we need to support communities so that disclosure, psychosocial support, it is what we need. Now, coming to what has stood out over a number of years with the HIV epidemic, I think this survey has been able to show us that there is a problem. And that's basically the purpose of statistics, to show us that there is a problem. But even more so, the survey has been very powerful in that it has been able to show us where the problem is.
Right.
So we not only know that there is a problem, but we can actually pinpoint and get closer to where the problem is. And for me, that is very valuable in this study. And also to highlight the gaps where we are with HIV epidemic.
Yeah.
Because it's not only about the numbers of people living with HIV. It's about what do we do about those people that are living with HIV.
Right.
Are we putting them on treatment? Are we maintaining them on treatment? Are they virally suppressed? That is what we need to do. And again, those that are not HIV positive, what are we doing about them?
Yeah.
Because we cannot brag that we are taking care of people that are living with HIV, but at the same time, we are not protecting those that are HIV negative so that they remain HIV negative. Because we don't want a situation whereby we move along with the pool of people living with HIV and we constantly add people.
Right.
We need to close the tap that brings people into the pool of people HIV positive, and we need to close the tap that actually get people living with HIV leaving the system in the sense that they die because of HIV and AIDS. So those are the two areas that we need to strengthen our interventions in.
I really like that, the perspective around not just looking at people who are HIV positive and the outcomes and behavioral indicators around that, but also how do we prevent it. I think that's such an important component to look at, because we do have a kind of culture of responding in our country, right? There's a problem, we respond to the problem, which means that the problem already existed for a while, really. And so by the time we respond, it's a bigger problem than if we were to just focus on prevention as well, in addition to responding. And so I think that that's, for me at least, a really nice kind of angle for people to kind of think about what prevention might look like over time. So thinking about where we are now, some of you have mentioned some of the things that are quite complicated right now. Where do we take SABSSM from here? So SABSSM's been here 20 years. You said earlier it was focused on specific things and it's evolved, right? So where to from here for SABSSM?
Obviously, what I would like to see going forward, at the moment, I would say we are at the mercy of our partners.
Right.
But the country needs to take responsibility. This is important data for the country, and the country needs to make a significant contribution to this work. That's number one. Number two, obviously, we are grateful that we've been able to expand to districts. To date, about 33 districts have been included. That is great. But of course, it pains me when we're in a meeting like this and a colleague sitting next to me and saying, but what about Umkanyabude?
Yeah.
Why didn't you include our area?
Yeah.
So I could be able to know what's going on in my community. And it pains one because saying, I would have loved to provide you with all the information, but we are limited by funding.
Yep.
So
Yep.
we need support to be able to expand and be able to provide information. Other colleagues were talking about the wards, for example. Obviously, to get to that level, you really need quite a big population. In this survey, the target, based on our calculation, of about 100,000 people to provide information that we're providing.
Yeah.
Adding more districts, that is increasing.
Yeah.
It costs a lot to conduct these studies. But information is power. We can only provide interventions on the basis of what we know.
Yeah.
So we do need that information.
Yeah, I think that's also such an important point, and I think you were speaking about it earlier, just about the partnerships that we need to create between civil society, government, but I think also in this instance between civil society, government, but also with funders, and in this situation to help really get down to that more micro level of understanding and representativity, I guess. So yeah, that's interesting. And for you, where would you, what's your thoughts around where to from here for SABSSM?
Yeah, so I think SABSSM is pointed to the gaps that we see. And from what the colleagues have said, that there are issues in the society. So it will be great if we can have social and behavioral studies to better understand and address the gaps, especially among men and youth. And for example, how do we promote health-seeking behavior among men to access HIV testing and prevention services? And how do we best support them once they get tested and they are found to be living with HIV? How do we support them so that they remain on treatment, or they initiate treatment first and then they remain on treatment?
Yeah.
And this kind of knowledge is key to tailoring health services to meet the needs of individuals so that they can stay on antiretroviral treatment for life.
For life, yeah. And I wonder, is there anything that's for you that is not in SABSSM? Like if you think broader, the implications of what we're learning through SABSSM, specifically the kind of behavioral indicators around just how that influences the health outcomes. Is there anything you would like to see added?
Well, I wouldn't say something added specifically, but maybe separate studies to explore more in terms of what we are seeing, why are we seeing this picture? Because SABSSM cannot give us the reasons why it's happening that way.
Yeah.
So if we can have something that can explore and help us understand why things happen the way they happen, and just to have, we have an idea like what colleagues have been saying, but we need it to be backed by data and science.
Right. And I guess also if we just practically think about surveys, the longer it gets, the higher the likelihood of people getting fatigued, completed, and all of this kind of thing. So it's also about being practical around that. So I like a suggestion about having separate or having SABSSM inform additional research. I think that's very practical. And for you?
I don't know now how I'm going to request it because already Prof is complaining about resource.
Question.
Well, our funders are here.
Yes. Speak the truth.
Yeah, particularly if you look at KZN, we remain as an epicenter for HIV.
Yeah.
The real burden is in KZN. So if we are not well equipped with all the necessary knowledge and information,
Yeah.
then we may always assume that we are winning. But I like the broader picture that was painted by Prof today. But I would have loved to take this further than to district, to look then what does it mean for Kingsejwayo, what does it mean for Itegu, what does it mean for Pietermaritzburg, because there are trends that we never seen before. So then is it our planning, because we're working with the government in KZN, is it actually trying to address some of the concerns that were raised by this particular study? Because our next step from now is to review the entire program, to look whether are we in line. Yebo, the national strategic plan is very, very clear and articulative then to say how we're going to respond. But we cannot ignore the facts that are coming out from this particular study. So in one way or another, we need to review to say, are we in line? Are we going to reach on these targets that we want? Yes or no? How can we then strengthen or either whatever that need to, but this is going to be continue then to be our advocacy tool in that regard. So maybe we need further analysis now. I don't know how possible is it on per district for KZN, so that I know we go to a provincial aids council to further advocate for mayors to get in, because political leadership is equally important. Sometimes we do not have a political buy-in and leadership in HIV. It's because mostly we leave them out and then we look at the managers. Yet if they were in a position of power to understand that the house is not just, there's no smoke, but the house is burning. How the emergency of the situation that we're in, well clear, articulated on a paper, then and also make them to understand, not just to say go and read, it's there. No, we need also the next step now to go to this different district and to say this is a challenge. But then if then this analysis can be furthermore clarified and bring it back and closer to home to those respective districts, then it will help them also to plan better.
Right.
Yeah.
And I think what you're saying is around that kind of bringing it again back to the micro level, right? And I think I often think about how do we make research accessible to people at different levels and in different ways, and in ways that we can navigate the finances, right? Because the struggle is real for research. You know, if we don't have adequate support and funding to be able to do what we need to do, it becomes, we have more limitations than we have access to what we want to do. But it's also thinking through how do we then engage and create opportunities where we can bring this home, while navigating this kind of struggle around funding and that kind of thing. So I think that's very, very important. So if our viewers want to get in contact with any of you before we end the session, how can they get in contact with you? I'm sure that there's been so much stimulated for them in this conversation. We spoke about gender, we spoke about communities, we spoke about funding, we spoke about the outcomes. And there's so much more that we could speak about, because there's so many questions that popped into my head and I have to zip myself because we only have a certain amount of time. But how can people get in contact with you if they want to just engage?
My number is 072 1826833.
Okay, great.
Or either on email.
Yeah, email is good.
patrick.mdleche@caprisa.org.
Okay, great. And with you? Just the email would be great, so you don't have to give a cell phone number out. But I think Patrick is brave.
Okay, my email address is nny3@cdc.gov.
Oh, great, great. Any socials? I need to ask.
No.
No socials.
I do, I just look at them.
Okay, sure. And with you, Kekalani?
Yeah, I'm reachable in our HSRC email,
Yeah.
kzuma, one word, @hsrc.ac.za, and can reach me on a Facebook platform
Yes.
using my name, Kangelani Zuma. You can get them. Or also sometimes, as and when I remember, I can be reached on X these days.
Oh gosh.
Kangelani Zuma came there.
Yes.
So yeah, can get me through those platforms.
And none of you are going to hold me accountable for all the emails you are going to get.
You just
I
find them
see.
to
No, this has really been such an interesting conversation for me. My work is public health, mental health, and I always say I'm a transdisciplinary researcher because I covered so many different things. But every time I listen to the SABSSM work, for those who don't know, I'm part of Kagalani's unit. I'm a daughter here. And it just creates such a new way of thinking. And I always think about how do things change, or why do they stay the same, and what increases the changes and all of those things. And so just well done on 20 years of work. And yeah, we're looking forward to maybe another 20 years. Are you still going to be here?
We'll see. Yes, I should be here, but not sure if I still have the energy.
Yeah, but we'll see. But yeah, thank you everyone for joining us today, and thanks to the panel. And we hope that the discussion today really gave you some food for thought around how you could use some of the SABSSM work in creating some additional studies. Maybe the CDC will fund it, we don't know. But just to create some more studies and interest around this work in order for us to challenge the challenges that we have in our society today. So thanks for joining us today, and yeah, we'll be back with the next session next time.
Thanks to you.
Thank you.
Thank you.
Thank you very much.